kind of jump off of another presentation I gave a few weeks ago. That one covered suicide risk assessments, but really was, it covered suicidality, but really how COVID is impacting suicidality. I thought today might be a nice chance for us to talk about suicide risk assessments, how to conduct them, what to look for, those different areas. I had prepped this with the thought that there may be some primary care doctors here today, but it seems like everybody is in mental health, and so I want to make sure that I'm covering things that are interesting and relevant to your work, and rather than reviewing things that you're already very familiar with. So quick survey: how many people have had significant training and feel pretty confident in suicide risk assessments? And no comments, except Aaron. I know Aaron is very well versed in suicide risk assessments, and if not, he should be. Nick as well. He doesn't get a pass on that one. But I'll just go into what I have. I have a lot of slides here today, and anybody can stop me with questions or if there's other topics within this area. This presentation focuses on adults, so it would be great if Amanda or Dr. Swagger could touch on children and adolescents with differences as well. Give me 1 second here. So the first thing today I'd like to talk about is some statistics. We covered these a few weeks ago, so I will cover them very quickly, very briefly. And then what I want to spend most of today focusing on is what's called the safety assessment. And it's just a way to conceptualize how to conduct a suicide risk assessment. I also have 2 handouts that go along with this presentation that Mitra has, and she will send out with the recording and the slides after today. So anybody want to guess why Robin Williams is on this first slide here?
I don't think there would be any guess as to why. I think we know why.
So Robin Williams, probably one of them, I'm trying to think if there's been more recently. There may have been more recently, but Robin Williams died of suicide in 2014 after years of struggling with substance abuse. Actually, he used a lot of cocaine when he was younger and alcohol, but had some years of sobriety and then relapsed again in 2003. Apparently in 2014, just prior to his suicide, he had been diagnosed with Parkinson's. He had been struggling with sleep and depression and restlessness. An autopsy after his death revealed presence of Lewy bodies in his brain, which they then suggested explained some paranoia that he was having and likely contributed to his suicide. So let's go through these pretty quickly, these numbers. Again, the most up-to-date data we have right now is 2018. But in 2018, there were 48,000 completed suicides in the US, an average of 132 per day, or 1 person every 11 minutes. It's the 10th ranking cause of death in the US, and the 2nd leading cause of death in adolescents and young adults. There was a recent study I saw that was looking at COVID, and I believe in Japan, and they have seen like huge spikes in suicide recently, which they are relating to the pandemic. And then as we've talked about before, and I'm sure has been covered in your training, there are 3.5 more male deaths by suicide compared to each female death, mostly because men are using more lethal means, such as firearms, in their attempts. A quick slide about West Virginia in particular. It kind of is similar, 10th leading cause of death in West Virginia, just as it is nationwide. The unfortunate statistic here is that West Virginia is ranked 8th in the number of suicides per the population. And that number 8 is not in the good direction. We would be the 8th highest state in suicide rates. And, you know, a lot of things and policy changes happen due to money and numbers. And so these statistics here about the cost of suicide in West Virginia are pretty staggering. And the hard part with studying suicide rates is that there are many deaths that are unclear whether it's suicide or not suicide. So these may actually be underestimates. Just a quick look at some of the means by which people complete suicide. Firearms, 50% of, and again, these are deaths. Sorry, let me clarify. These are deaths, not attempts. And this is that table that kind of explains why there's more deaths for men by suicide than women. The 50% of suicide deaths are by firearm, 28% by suffocation, 12% by poisoning, and 7% with other means. Just had some like quick little information for you about suicide, including suicide notes. And so I thought this was kind of interesting because I think there's many people out there that believe that most people write a suicide note. But what the statistics show us is that only about 20 to 25% of adults actually leave a suicide note, and only 5% of adolescents do. This is suggestive that adolescents are much more impulsive in their suicide attempts, and that leaving a note takes some more thought and deliberation that maybe adolescents don't take the time to consider. But we do know that their research has looked at those who leave notes and those who don't, and they've not found any kind of demographic or mental illness based differences, except that individuals who leave suicide notes tend to have had more prior attempts previous to the completed suicide, and that they're more socially isolated, which is not good given our current pandemic. This slide here talks about a suicide continuum, and I think this is important when you're thinking about suicide and how to proceed with suicidal ideations and what kind of levels of service or care an individual might need. And it's this idea that it's not attempt suicide, no thoughts of suicide, but that people can range on a continuum. Their place on that continuum can change very rapidly. And it's this idea that we can start with no suicidal ideation, and then there's lots of steps in between. And right in the middle, we have this shift from ideation into kind of action or planning. And then there's lots of places in between this shift to a completed or even a suicide attempt. So I briefly want to touch on a few models that try to help explain why or how suicide happens. And this is one that I always come back to. And this was, I consider this the Joyner model of suicide, but it's also called the interpersonal model of suicide. And it's this idea that it takes a desire to want to end one's life plus a capacity to an acquired capacity to actually engage in the behavior required to end one's life. That equals a suicide attempt. And so under desire, what Joyner really focused on was these two ideas, an idea of perceived burdensomeness and this idea of failed belonging. So perceived burdensomeness is the idea that a person's existence burdens other people. This could be a health problem. So maybe a person has cancer and is relying on family and friends and feels like he or she is burdening them. They view themselves as a liability to others. And then keep in mind, when Joyner was looking at this, he's looking at perceived burdensomeness, and that perceived is important. The individual considering suicide believes that he or she's a burden to other people, but not that they actually are a burden to other people. And the other idea is the other part of desire is this failed belongingness. This is isolation, feeling of being alienated from others, not an integral part of a family, circle of friends, or a valued group. Research has found that women with children have lower suicide rates than those with no children, despite higher levels of stress. And the thought behind this is that children, having to care for children, being a full-time job, gives people a sense of belonging, gives them another person to count on. Also, twins have higher rates of mental disorders. They actually have lower rates of suicide. Researchers believe it has to do with this belongingness, less isolation. And then getting into the capacity side. Joyner believed that humans in general don't all have the capacity to engage in a painful behavior that, likely a painful behavior, that would be necessary to engage in suicide. However, he was very aware that through life experiences, some people do have that capacity, and that that capacity is necessary in order for somebody to engage in suicidality. And some thoughts about this acquired capacity include really painful, provocative experiences in a person's life. This could be chronic illness, could be victims of trauma, combat exposure. It could be this habituation to injuries or death that makes a person unafraid of their own death. This is suggestive of people in the military, police, EMTs. They become very desensitized to these painful, provocative experiences. And then there's also the concept of self-harm. Although the behavior of self-harm is not indicative of suicidality, it's often done for other purposes rather than for the person to die. The behavior of repeatedly engaging in self-harm suggests that a person is habituating to pain and maybe gaining that capacity to cause harm to oneself. And so I think these are really important to think about when I'm evaluating somebody. I watch out particularly for the desire pieces, and then kind of in the back of my mind when I'm thinking about their history with the capacity. In the back of my mind, I'm listening for things like, I don't want to burden my family anymore. I am isolated. I don't have anyone. I'm all alone. Those ones suggest to me that I need to really think about their other risk factors and their protective factors and really balance them out with each other. Again, please, I can't see everybody's picture, so stop me at any time if you have questions or just comments. Experiences with clients that have fit any of these models. One more model to talk about, because I think it's also important, is McKean thought that there were two different pathways to suicide risk. He thought there was an acute risk pathway and a chronic risk repeat attempter pathway. And the way he looked at it is with these acute risk individuals, they have multiple stressors and losses, perhaps kind of compounding on each other in a short period of time. Those stresses and losses lead to depression, feelings of depression, which lead to feelings of hopelessness, which lead to a suicidal act to escape from that acute psychic pain. And then the idea for treatment for those individuals, treat the depression, possibly medications plus CBT or interpersonal psychotherapy with IPT, and you lower the suicide risk. That's a different pathway, that's a different treatment option for individuals that are chronic risk repeat attempters. And these, initially what comes to my mind is people with personality disorders. So for those individuals, the suicide risk is that they have this difficulty, struggle with emotion regulation. They have frequent, intense, negative emotional states. So they lack the skills in emotion regulation, which then leads to frequent and intense negative emotional states, which then leads to suicidal behaviors. But the reason that it's leading to suicidal behaviors or suicidal acts is to escape the chronic state of pain that they're in, or to escape or is interpersonally reinforced. So every time I attempt suicide, I end up in the hospital, people pay attention to me, my family starts coming around to check on me, and it gets reinforced interpersonally. So the mechanisms for why a person engages in these acts is very different between acute and chronic. And additionally, how to treat it would then be different. So in order to treat that chronic risk and repeat attempters, you're looking more at dialectical behavior therapy. You're looking at treating the underlying personality disorder. You're focusing less on acute stressors and more how do we gain these skills to help manage these intense emotional states. And while I think all of this are things that likely everyone here has learned, I think it's nice when somebody puts it in a package that we can say, oh, yes, this explains this person's behavior because this is that model of the suicide risk pathways, or, oh, yes, this is how this person acted, but there's a name for it. It's the interpersonal model from Joyner. Just a reminder, suicide risk assessment is not an event. It's not a one-time thing. It's a process. It's something that we as clinicians do frequently and are always keeping in the back of our mind with all of our patients. And that may just be that I think of it as something that I always have back there, but I'm not always actively using. I'm not actively doing a checklist of all their risk factors for suicide, but that's because maybe I know their history, or I know that that hasn't been an issue in the past and nothing has changed to suggest it's an issue now. So it's always something that's there. It requires repeat assessment of risk and protective factors in specific contexts at specific times. And the more that we work with and know individuals, the more we kind of always have these risk and protective factors. We know what their chronic risk factors are. We know what their protective risk factors are. And then if something in their life changes, then we need to start shifting our conceptualization of those factors. So let's look at the safety. The nice thing, and this was actually what we used and thought about when I worked in an emergency department in North Carolina. And it's a 5-step evaluation and triage. And I like it because it's a quick way to remember things. And so with the safety, what they want clinicians or evaluators to do, first we want to identify what is this person's risk factors for suicide. Then we want to identify what are their protective factors that are keeping them from harming themselves. And then we need to conduct a suicidal inquiry, which sort of is looking at risk factors, and many people may actually do this inquiry when they're considering what the risk factors are, but it's really kind of an idiographic way of looking at their specific thoughts, plans, behaviors, and intent. And then the next one is to determine what is their risk level, and based upon that risk level, what level of intervention do they need? And then lastly, and the most important one, is to document. And one of the favorite phrases that a supervisor of mine used to tell me all the time is that if you don't write it down, it didn't happen. If you don't document it, it didn't happen. It doesn't matter if in your head you did this awesome risk assessment and you determined they were at low risk and could be released. If it's not documented anywhere, it's not helpful. So the last part, although kind of mundane, is really important. So we're going to go through each of those 5 steps, really the first 4 steps of the safety, to talk about what are some risk factors, what are some protective factors, how do we do a suicidal inquiry. These might get a little overwhelming. Remember, Mitra is going to send out these slides to you, so you don't need to get all this down right now. But thinking about risk factors, there's different types of risk factors. The first one they call is perpetuating risk factors. This means these are also, I would call them static risk factors if I'm using the language that I use for violence risk assessments. And that's this idea that these are factors that are unchanging. These are factors in a person's life that can increase but are never going to decrease, because they're things that don't ever go away. So a person could add additional perpetuating risk factors, but again, none of them are ever going to be taken away, because they could be demographic things. Person is not changing their ethnicity. They do get they would get older with age, so that may shift, but it's never going to go back, right? They're never going to get younger. Marital status, early widowhood. This is talking about kind of top concerning categories. So we know that whites, compared to other minorities, are more likely to engage in suicide. We know that males are more likely to complete suicide than women. We know that American Indians are, Native Americans are more likely to engage in suicidal behavior than other groups. We also know that older age is more likely to result in a completed suicide. The next one, the one I think about for this is the best predictor of future behavior is past behavior. And so a history of suicide attempts, especially if it's multiple suicide attempts, is always going to be a risk factor. Those are individuals whose risk, even at baseline, is higher than everybody else's. And so keeping that in mind, if their risk level is always higher, a little stress for this person could put them over the threshold of suicide, whereas a little stressor from this person still keeps them below that threshold. Prior suicidal ideation, again, these are all historical things, right? Do they have a history of self-harm? Do they have a history of suicide in their family? Do their parents have a history of substance abuse, violence, hospitalization, divorce? Does the individual have a history of trauma, psychiatric hospitalizations, violent behaviors, impulsive behaviors? And so some statistics just to throw out there, when a person has one previous suicide attempt, it increases their lifetime risk of completing suicide by 10 to 15%. And if they have 2 or more previous suicide attempts, it increases their lifetime risk of completing suicide by 15 to 30%. So those are important to keep in mind when thinking about a client and their potential for engaging in suicidal acts. Important diagnoses to keep in mind, mood disorders, most common, 60% of individuals who complete suicide have a documented mood disorder, schizophrenia, substance abuse, and personality disorders. Research suggests that 90% of people who complete suicide have a DSM diagnosis. 90% of adults have a DSM diagnosis, but with adolescents, only about 60% of them have a DSM diagnosis. Let's look at more risk factors. These ones are called predisposing and potentially modifiable. Also could think of these as dynamic risk factors, meaning these are things that are important to think about and they're current, present, but they're modifiable, right? We can treat a mood disorder through therapy, through medication. We can treat schizophrenia. We can treat a personality disorder. And so these are important to consider: psychiatric diagnoses, mood disorders, anxiety, schizophrenia. Substance use is a big one. Eating disorders, even conduct disorders, cluster B personality disorders, and definitely comorbid disorders if you're looking at depression. If you're looking at a mood disorder with a substance use disorder. Traumatic brain injuries, again, some of these TBIs, you're thinking they're more impulsive, maybe it's affected an area of the brain that's made them more emotionally labile. Low self-esteem, high self-hate, tolerant or accepting attitudes towards suicide, exposure to another's death by suicide. Sometimes this is called contagion. It's this idea that there may be a suicide, there's a spike in suicide, suicidal acts when people in a community, when someone in a community has just completed suicide, or even when celebrities have completed suicide. This looks at sexual minorities, LGBTQ individuals have an increased risk of suicide. They've also found smoking to be a risk factor, and perfectionism. So especially perfectionism in the context of depression. Again, that feeling that they have to be perfect, but then there are symptoms of depression likely interfering with it. Then we have acute risk factors. So these are recent changes in a person's life that takes them into that kind of acute risk phase. So recently getting divorced, recent suicidal ideation, reoccurrent self-harm, recent attempt, excessive or increased use of substances, psychological pain, but acute distress, maybe a loss, a rejection, financial changes, loss of a job for many people is a risk factor. Recent discharge from psychiatric hospitalization, I believe it's, and someone can correct me if this is wrong, but I believe within the first 30 days of leaving a hospital is an important time to think about. Anger, rage, seeking of revenge, aggressive behaviors, people withdrawing and isolating from activities, anhedonia, anxiety, agitation. Sleep disturbances are a risk factor for suicide. Like I said, long list here. Some other acute factors to keep in mind, suspiciousness, paranoia, dramatic mood changes, hopelessness. That kind of goes with that perceived burdensomeness in Joyner's model. Recent diagnosis of a terminal condition, feeling trapped, being impulsive, reckless, or excessive risk-taking behaviors. And then the one that comes to my mind often in my forensic work is short-term incarceration. So there is a huge risk factor for suicide when somebody enters jail. And so this is looking at, what you see is the orange here is the number of people per 100,000 who commit suicide by incarceration type. So it's not just that a person's incarcerated that increases the risk for suicide, but it's actually something about jail. And you'll see that it's kind of shifted over time, but there's definitely a discrepancy, right? This is, the yellow is the US suicide rate. State prisons is higher than the US rate, but jails is exponentially higher in risk of suicide. And a lot of that is because it's that acute, it's like the first 2 to 7 days that a person's in jail that really increases their risk of suicide. Might be because the kind of uncertainty of what's going to happen, complete change in their life. Maybe they're withdrawing from substances, but jail is a really big problem. We also are, I can speak for West Virginia, our jail system is, they're not structured the same as our prison system. There's less oversight, they're more crowded, and they don't have the mental health care that even our state prisons do, which even we know that those may not have enough mental health care, but they're better than jails. And so these are triggering stimuli. These are things to think about if your patient has one of these events, types of events happening, that it may make them more vulnerable to suicide. So we talked about that contagion, which is the second point here. But the other is a real or anticipated event that would cause or threaten, that would cause them to feel shame, to feel guilt, to feel despair, to be humiliated. Maybe it's an unacceptable loss of face or status. Legal problems, losing freedom, there goes to that, speaks to that jail. Financial problems, feelings of rejection or abandonment. So those are some of the risk factors that increase a person's risk of suicide. But what are some protective factors? The key place to start with protective factors with clients is to talk about what are their reasons for living. That kind of gives you a gauge of, are they even able to have this flexible conversation about not going through with this suicidal act. Some external reasons for living or protective factors for people include responsibility to children or pets. Pets can be a huge reason for living. Positive therapeutic relationships, you know, getting someone to agree that they, or talk about that they want to come back to therapy next week is important. Social supports, family, friends. Again, we're lowering that isolation, and less isolation is protective. And then internal protective factors, ability to cope with stress, frustration tolerance, and religious beliefs. It's important to note that many religions don't agree with suicide or claim the person will go to hell if they complete suicide. And so talking to people about what has them holding on, and oftentimes religion becomes a big piece of that. Let's talk about the suicidal inquiry. And so we talked about these kind of risk factors, but this is talking to the person specifically about what is going on with them right now in regards to suicide. And this is the idea that I think all these positive behavior support people on this call will recognize this as, right, this is very behavioral. We want to get down to how frequently are they thinking about suicide? How intense are those feelings when they're thinking about it? How long does it last? And so these are some things in the last 48 hours. How often have you thought about it? How intense were those thoughts? How long did those thoughts last? And so this is helping you kind of narrow down. Some people may be chronic, serious, repeat attempters. And for those individuals, you can't say, okay, we're going to go through every single suicide attempt you've ever had, and we're going to talk about how you feel. But I think I always look at it as, tell me about the last 48 hours, how things are going, how things been going the last month. What did it look like the first time you had these thoughts, and what about the worst time? And then we talk about their plan, and this is where you're looking at that worst, first, most recent. What's the timing? Where's the location? What means is a person using, which would speak to lethality? How available are those means for the individual, and what acts have they taken to start to prepare for that? We want to talk to them about past attempts. What do they look like? What means have they used in the past? Do they have aborted attempts? And was this aborted by the individual or aborted because someone else intervened? Rehearsals. Do they practice tying a noose because they are thinking about hanging themselves? Do they load and unload the gun? Do they get the pills out and count them and put them back? And then you can also look at non-suicidal self-injurious actions. And then what's the intent? How much does this person think they expect to carry out the plan? Do they believe the plan is going to be lethal, or is it more self-injurious? Explore some of that ambivalence, using some of those motivational interviewing skills. Reasons to die, reasons to live. And then once the risk factors and the protective factors and your suicidal inquiry is done, let's put together a risk formulation. And this is the one that's used on the safety handout, thinking about, what do I do? Where do I put this person? And this isn't that we don't have a great checklist. You have 5 of the 15 risk factors, therefore you're in the high category. It's still a clinical judgment, but it's this idea of kind of what the factors look like and then what level of care do they need. And so the first here is, I cut off something, so I'll have to get that other handout, but you're looking at some of what are their risk factors. For low, they've got modifiable risk factors. Maybe they have some of that mental illness, but they still have some strong protective factors. So if that's the case, they may also be having, this is your suicidal inquiry, right? They may have been thoughts of death, but they don't have a plan, they don't have any intent, they haven't engaged in any behavior. So what do they need? Well, maybe they need an outpatient referral. Maybe they need to be given emergency and crisis numbers, and they need to work on reducing some of their symptoms, particularly of those modifiable risk factors. Then we jump up to the moderate category. These are individuals with multiple risk factors and have very few protective factors. They have ideation, but they have a plan, but they don't intend to engage in that plan, and they haven't moved forward into attempting. And this one is like, that's the hardest group, right? These are individuals where admission to a psychiatric facility may be necessary, depending on what those risk factors are. These are people you want to develop a safety plan with. These are people that giving crisis numbers is important. And then your high risk category, I find that the low and the high are pretty easy to make a decision, right? Low, you're like, okay, they're okay if they just get us some outpatient services. High, they've left me no choice. They need to go to into the hospital. The moderate's that hard one where it's kind of iffy whether or not those increase in intervention steps need to be taken. High, we're looking at psychiatric disorders with severe symptoms, acute or there's been some acute precipitating event. There's to the point where the risk factors outweigh any protective factors the person may or may not have. Maybe this is a person who has engaged in a potentially lethal suicide attempt and survived, or they have persistent ideation with strong intent. They've been rehearsing suicide. Generally, admission to a psychiatric facility is warranted, and then within that facility, they should be taking suicide precautions. So, kind of looking at Robin Williams' case, again, like we mentioned in the beginning, he had some chronic risk factors. He was an older adult white male with a history of substance use and a chronic illness. He also had acute risk factors for suicide. He had a recent loss. He was currently experiencing depressive symptoms, feelings of burdensomeness. He had that separation from his wife. He was sleeping in another bedroom separate from her. Paranoia, insomnia, anxiety, and feeling socially isolated. So he had a number of these risk factors that we have been talking about. Last thing I want to touch on before we finish is you've completed the assessment, you've assessed them for risk. So what do you do after that? Now, this is not for that high risk group that we were talking about, but more for the moderate and maybe even the low. And that's where I just wanted to touch on safety planning. There is another handout that will be given to you that shows a template of a safety plan. It's a template that Chestnut Ridge is suggesting that we use with patients. It's a bit more detailed than the one I actually tend to use, which is more just off the top of my head and not one that's already printed out. But I think it's a very good safety plan. It's important to keep in mind there's a difference between a suicide contract and a safety plan. We know that suicide contracts do not work. They are ineffective and they are not going to save you in court if you use one of them. They create this false sense of professional security. It's this idea that if my patient signs a form saying, I will not complete suicide this week, and they sign their name, that it gives us this sense of, well, they've agreed they won't do it, so if they do, I couldn't have predicted it, which isn't true. It's also not helpful, as we know from treating mental illness and helping people change their behavior, that we're instructing them with a suicide contract in what not to do. We're telling them, do not attempt suicide. Rather than the safety plans, and the safety plans tell a person what they can do. When you are feeling suicidal, here's what you're going to do. Step 1, if that fails, step 2, if that fails, step 3, if that fails, step 4. And the reason that we believe that safety planning is effective and works is that it's an intervention in and of itself. This is you going through and reviewing what are their coping skills, who are their support systems, what numbers can they call. You're rehearsing, you're practicing this, you're giving them something physical to take with them. And all of that is an intervention in and of itself. And so with a person, you want to ID the warning signs, right? You want them to know when I have this thought or when I start doing X, that's a problem. When I isolate from my family, when I sleep all day, when I don't show up to work, those are warning signs. Then what are your top 5 coping strategies? Which ones work the best for you? And that may mean teaching a coping strategy to people if they don't have one. Then what are some social resources? What are things, and this one gets hard with the pandemic, what are some things you can do when you're feeling this way to distract yourself? Who are some people you can call just for support? And who are some people you can call who could help you in this situation? Lastly, what are some professional agencies that could help? And then the last one is environmental safety steps. So this is like restricting means access or access to means, such as locking up knives, locking up guns, locking up pills. And that is all I have. Questions?
Awesome. Thank you so much, Dr. Lillard. That was great. Any questions or comments for Dr. Lillard? Feel free to unmute as well. I had a quick question for you, actually. Have you seen or read any studies that differentiate between accidents versus an intentional suicide with, let's say, like a very intentional means, like a firearm?
So I haven't. We'll see if Dr. Swigert or Amanda have any thoughts. But my first thought is that's why we have kind of likely an underestimate of suicide, is because it's really hard to determine accidental versus intentional. And I believe they tend to go towards the accidental if they can, or if they don't have enough to support the thought that it was suicide.
I don't know either. I think it's probably a little bit easier in the firearms category because they can study ballistics and look at like trajectories and placements. The far harder area to kind of differentiate, I think, is the overdoses, where it's unclear if people like just took too much medicine to sleep or weren't aware of the safety, or if there was a real intent. Or what we often see in substance use is you know, a lot of people struggling with emotional problems in the context of substance use, maybe using the substances to get high, but also maybe struggling with kind of ambivalence about being alive, and can certainly kind of cross the line and sort of risk it, so to speak. And so I think while I'm sure that happens to some degree with firearms, I think the biggest area where that differentiation is far harder is overdose.
Yeah, thank you both very much. Any other comments, Carmen?
One thing I wondered about is whether you've done any research on suicide combined with homicide. That's something I struggle to understand. Is it's very sad when someone decides to complete suicide, but when they decide to take others with them, like family members or just others in the community, I just wondered if you have any comments on that.
Yeah, those are really tough ones to think about and to hear. I come back to Joiner's interpersonal model there, and this idea of being a burden, and this thought that they have burdened this other individual, and so by taking them with them, that burden is gone. If we leave the pet and I complete suicide, then I can't, nobody's there to take care of that pet, and it's going to be in more pain or suffer more than if I engage in that behavior as well. Sometimes with those murder suicides, you're looking at, it's kind of revengeful and vindictive, like you've taken these children away from me, you've taken away my custody, and so I'm going to hurt you in the worst possible way. That could be pets, that could also be family members. I look at also like financial burdens in individuals, and so if they have done something and lost everything, the family has no money now, and them feeling like I can't leave them in this place, and that's, you know, just thinking of the I want to say average individual, but not even getting into like delusions and kind of some more severe mental illness with that. You also have like suicide by cop scenarios where individuals, I know Erin's seen that a number of times at Sharp, but these are individuals who maybe I think of Joiner's model and the capacity. They might not have that capacity to engage in the behavior themselves, but feel very strongly that they don't want to live. Therefore, take it out of my hands, hold a gun to an officer, and he's going to kill me. That's a very good question, Carmen.
Are there any other comments, questions, or maybe experiences that you'd like to share, anyone with the group? All right, and like Dr. Lillard mentioned, I will be attaching those two references